Start हुआ? Okay. Assalamu alaikum. Today we are discussing the bleeding disorders and the hemorrhagic diagnosis. Now, the causes of the excessive bleeding. It may be due to the increased fragility of the vessel wall, platelet deficiency or dysfunction, and rearrangement of the coagulation. These are the causes which can lead to the excessive bleeding. Now, one by one, we will discuss all these abnormalities. Increased fragility of the vessel wall may be due to um, some disorders that may causing the disturbance or may lead to the vessel wall abnormalities. These are the disorders, these are the common one, and they do not cause any serious bleeding. Most of them, they are presented with petechiae and the purpura and the skin or the mucous membrane. In this condition, when there is a abnormality of the vessel wall, the platelet count remain normal, and the coagulation profile as PT and APTT are also normal. Now, what is petechiae and what is purpura? Petechiae, these are the tiny flat lesions, reddish to purple in color, and these are the non-blanchable lesions. They are less than 0.5 centimeter in diameter. They are just pinpoint lesions. You can witness if there is a vessel wall abnormality, you can witness if there is a decrease in the platelet count. So petechiae can be there. Purpura, these are the flat lesions. Again, it is reddish to purple vascular lesion, non-blanchable, but they are greater than 0.5 centimeter in diameter. Also, we can witness if there is bleeding, diathesis or platelet deficiency भी हो सकती है, PTA, PTT भी derange हो सकता है, and it can, there may be a vessel wall abnormality. So these are the basically symptoms if there is a decrease or there is a bleeding diathesis or bleeding disorder. So these can be the symptoms that a person have. The petechiae and the purpura. These are the differences between the petechiae and the purpura. And the bleeding disorders that are caused by the vessel wall abnormality, it may be due to the infections. Examples are the meningococcemia, infected endocarditis, rickettsia. Number of the other infections can lead to the vessel wall abnormality. Maybe a drug reaction that leads to the leukocytoclastic vasculitis and leads to the vessel wall abnormality. Scurvy and Ehlers-Danlos syndrome, there is a lack of the collagen support, so that makes the vessel wall weak. The senile purpura and Cushing syndrome, this is the Knox-Furlian purpura, which is a immune complex disease, and this leads to the vessel wall abnormality. Hereditary hemorrhagic telangiectasias, these are the in this conditions, the vessel become tortuous. So that may lead to the vessel wall abnormality and the bleeding. Systemic amyloidosis. So these are the few causes of the bleeding of vessel wall abnormality that leads to the bleeding disorders. Now, bleeding related to the thrombocytopenia. The term thrombocytopenia indicates the reduction or includes the reduction in the platelet number. This is known as a thrombocytopenia. So bleeding resulting from thrombocytopenia is associated with normal PT and APTT because this is the coagulation profile. So यहाँ पे आपके जो clotting factors हैं वो affect नहीं हो रहा. That's why the PT and APTT will remain normal. Only the platelet count will decrease, and this is known as the thrombocytopenia. This is the normal count of the platelet. It ranges from 150,000 to 450,000. So thrombocytopenia, if it is less than 150,000, and risk of bleeding, post-traumatic bleeding is if the platelet count is less than 20,000 to 50,000. Spontaneous bleed may occur if the platelet count falls below the 5,000 microliter. So bleeding disorders due to decreased platelets. It may be due to decreased platelet production. It may be bone marrow dysfunction हो सकता है, कोई drug ले ली उसकी वजह से bone marrow की suppression हो गई. So that leads to decreased platelet production. Decreased platelet survival. there is इसमें क्या होगा कि normal production हो रही है bone marrow से, but the survival time, which is normally 7 days in a circulation, this will be reduced. जो platelet survive नहीं करेगा, it will survive for lesser period of time, 2 or 3 days or 4 days or 5 days, whatever. The sequestration, this is like hyposplenism or hypersplenism that leads to, अगर आपको splenomegaly है, that leads to the increased destruction of the platelet and dilutional transfusion. If the multiple transfusion can lead to the dilutional effect, may lead to dilutional effect, and that decrease the platelet count. So these are the few causes that leads to bleeding disorders. Okay, due to decreased platelet count. Decreased platelet production may occurs maybe due to the aplastic anemia, bone marrow suppression, maybe leukemia, certain drugs, alcohol, and HIV. Decreased platelet survival, it can be immunological and non-immunological. Autoimmune, this leads to the idiopathic thrombocytopenic purpura and ASL. Isoimmune alloantibodies post-platelet transfusion cross the placenta from fetus into the pregnant mother. Non-immunological causes include DIC, the thrombotic microangiopathies, and the mechanical injuries. Now, chronic immune thrombocytopenic purpura ITP. It is chronic bhi hota hai, acute bhi hota hai. Chronic ITP is caused by autoantibodies mediated destruction of the platelet. It can be primary or idiopathic or secondary. The pathophysiology, the autoantibodies are usually formed against platelet membrane, glycoprotein 2B3A or this 1B9. These are of IgG classes. Principal changes found in the spleen, bone marrow, and the blood. This is the pathophysiology of the chronic ITP. Here you can see the platelet. Okay, this is the anti-angel binding portion of the antibodies. This is the binding. Here you can see this is the antibodies to the platelets. So the antibodies to the platelets, this is the FC portion of the that will fix the complement systems. This antibody will bind to the platelet, and after the binding of platelet, this complex is formed, platelet antibodies. ठीक है, ये पूरा एक complex form हो जाएगा. Now this complex will be recognized by the macrophages as a foreign. Now they're trying to engulf or trying to remove this. So phagocytosis will occur, and then subsequent destruction of the platelet. Right. So this here you can see this is the macrophage in the spleen, and this is the complex platelet and antibody. Antibody, this is the autoantibodies that are formed against the platelet. There's a binding between the antibody and the platelet. Now this complex is recognized by the macrophages as a foreign invader or foreign material, and they are taking up for the destruction. And in this way, there is decrease in the platelet count. This has been maybe of normal size, condition of the sinusites, enlargement of the splenic follicles, path of blood, large platelets, megathrombocytes, so there are signs of the accelerated thrombopoiesis. If there is an increase in the destruction of the platelet or decrease in the survival of the platelet within the circulation, the bone marrow will try to compensate this loss. So the bone marrow will form more and more platelets. So that may lead to the megathrombocytes in the circulation, which is a very important sign of the accelerated thrombopoiesis. Here you can see the normal platelet. ये आपको pinpoint से लग रहे होंगे as compared to these ये RBCs हैं, and then you can see the platelet. Here you can see the megathrombocytes. It's a larger one. You can compare the two pictures. This is most commonly in women under 40 years of the age, female to male ratio 6:1. It may lead to cutaneous bleeding, pinpoint hemorrhage, petechiae, easy bruising, nosebleed, bleeding from the gums, melena, hematuria, excessive menstrual flow. It may lead to the subarachnoid hemorrhage, intracerebral hemorrhage, splenomegaly, and lymphadenopathy. These are the complications. Findings, as you know, there is decrease in the platelet count, so PT and APTT will be normal. There may low platelet count, normal increased megakaryocytes in the bone marrow, and large platelet in the peripheral blood. Treatment we can give the glucocorticoid, steroids दे सकते हैं, and we can remove the spleen to stop the sequestration. So splenectomy can be done. Acute immune thrombocytopenic purpura. This is a disease of childhood occurring with equal frequency in both sexes. Usually follow a viral illness that limited, usually resolving spontaneously within 6 months. acute immune thrombocytopenia, the pathogenesis of this acute thrombocytopenic purpura. So again, this is maybe due to some viral infection in the children. So again, the autoantibodies are formed that is directed against the platelet membrane antigen, especially the glycoprotein complex 2B and 3A. Then this complex is recognized by the reticuloendothelial system, the macrophages, and phagocytosis will occur and increase the destruction of platelets. And that leads to thrombocytopenia. Drug-induced thrombocytopenia, drug can induce thrombocytopenia via these mechanisms. Okay? Direct effect on the platelet, secondary to immunological mediated platelet destruction. The drug most commonly implicated are the quinines, quinidines in the antiviral, antimalarial drugs and some of the antibiotics, vancomycin, which is also common consequences of platelet inhibitory drug that binds to this portion of the platelet, the glycoproteins that are present on the platelet. Here you can see the drug-related thrombocytopenia, drug-induced cytopenia. Okay, drug can induce thrombocytopenia to direct effect on the platelets and secondary to immunological mediated platelet destruction. Right? दोनों हो सकते हैं. So the drug most commonly, this is here you can see the quinine-dependent antibodies. This will form and the new antigen emerges after the conformational changes induced by the drug binding. This is the drug binding site up there, and here's the antibodies. So there is attachment of the antibody with the drug binding site, and the conformational changes will occur. That leads to the platelet destruction. Now, the heparin-induced thrombocytopenia, the heparin-induced cytopenia has a very important because it's of particular importance because of potential for severe clinical consequences. This is one is the heparin-associated thrombocytopenia, other is the heparin-induced thrombocytopenia. So in this, you can see these the thrombocytopenia that occurs after receiving the heparin, right? So most develop so-called type 1 thrombocytopenia, which occurs rapidly after the onset of therapy and of little clinical importance, sometimes resolving despite the continuation of the therapy. So this is the heparin-associated thrombocytopenia. This is the type 1 thrombocytopenia, heparin-induced type 1 thrombocytopenia. Type 2 is the induced one, heparin-induced thrombocytopenia. It's more severe one and it is more clinically important. Okay. So this may, you can see this is the protein, the PF4. This is the protein that are present on the platelet. And whenever the patient is given the heparin, the antibodies, they are formed and these are attached to this part of the platelets. Okay, heparin is attached hoga, and then these antibodies get attached to this part of the platelet and they form a complex. The immune complex is formed. This complex is formed. Okay, ये heparin है. Okay, ये इस part से repeat F4, and this is a protein that are present on the platelet. They form a complex. The antibodies recognize this complex and get attached to the platelet. So when they pass through the spleen, the platelet removal by the splenic macrophages leads to the thrombocytopenia. Or when this complex has, it may activate the platelets, other platelets. So the platelet activation process due to release of certain chemokines, and the platelet release hoga, aggregation hogi, and that may lead to the thrombosis. So this is heparin-induced thrombocytopenia, and this thrombosis may be a generalized one, and it may lead to decreased platelet count due to the consumption of the platelet that leads to the thrombus formation. So binding of, again, I'm repeating this, binding of this antibody to this complex, the heparin and this protein complex will lead to activation of the platelet. It will cause the aggregation, causing the consumption of the platelet that leads to the thrombus formation. Thrombus तो form हो गया, but ultimately, as due to the consumption of the platelet, it leads to the thrombocytopenia, may lead to bleeding diathesis, or bleeding problems. HIV-associated thrombocytopenia is one of the most common hematological manifestation of HIV infection. It is due to impaired platelet production हो सकती है, increased platelet destruction. So these are the helper cells, and this is the receptors, and the co-receptor for HIV are found on the megakaryocytes. These are the present and allow these cells to be infected and removed from the circulation of the body. So this leads to thrombocytopenia. Bleeding disorder related to defective platelet functions. The qualitative defect of the platelet function can be inherited or the acquired. So inherited disorders of the platelet function can be classified into three pathological distinct groups: defect of adhesions, defects of aggregation, and disorders of platelet secretion. Bernard-Solier syndrome. This is a syndrome that is caused by an inherited deficiency of the platelet membrane glycoprotein complex 1B and 9. This glycoprotein is a receptor for von Willebrand factor, is essential for normal platelet adhesion to the subendothelial extracellular matrix. Here you can see the deficiency of this. Whenever this endothelium get exposed, there is expression of von Willebrand factor. For von Willebrand factor, this must be there's this glycoprotein. So if there's a deficiency of this protein, this platelet won't attach to this von Willebrand factor, or the adhesion will not occur. So this is known as the Bernard-Solier syndrome. Another disorder is the Glanzmann's thrombocytopenia. This is bleeding due to the defective platelet aggregation because of deficiency or dysfunction of glycoprotein 2B and 3A, and integrin that participate in rich formation between platelet by binding fibrinogen. Okay, so here you can see again this picture. So this is the binding will occur, aggregation होगी यहाँ पे, and if there is deficiency of this, that will lead to there is no aggregation. So this is known as a Glanzmann thrombocytopenia, right? So ये जो bridging formation होती है, plug formation होता है, that will not occur, and that leads to platelet aggregation defect and Glanzmann's thrombocytopenia. This is again the similar thing. You can see the von Willebrand factors deficiency हो सकती है. It may be the deficiency of the glycoproteins. Maybe this adhesion नहीं होगी यहाँ पे, और aggregation नहीं होगी. So this is on the overall picture, just showing you the Bernard-Solier syndromes and the Glanzmann's thrombocytopenia. Disorder of the platelet secretions are characterized by the defective release of certain mediators of the platelet activations, such as thrombosin and the granule mount ATP. Some of the acquired disorders may be due to the ingestion of the aspirin and other non-NSAIDs. की वजह से हो सकता है. Aspirin is a very potent one that causes irreversible. This is irreversible inhibitor of the enzyme cyclooxygenase, which is required for the synthesis of thrombosin A2 and prostaglandins. And other condition is uremia, which may lead to the platelet function defect. Okay. So this is all about the bleeding disorders. Thank you.
Zoom इसमें एंड मीटिंग का ऑप्शन आ रहा है. ये स्टॉप करें, स्टॉप शेयर करें हम। ये नीचे एंड लिखा हुआ लास्ट, ये एंड, अब मीटिंग एंड, अब वो कन्वर्टिंग ऊपर वाला, अब वो कन्वर्टिंग